It is wild to think about, but just a few millimeters of bone right at the bottom of your face can completely alter whether people see you as, like, a submissive pushover or this aggressive, confident leader.
Yeah, it really is a massive psychological driver in our society. I mean, we are just instinctively wired to make these snap judgments about personality, and it is based entirely on the geometry of the jawline.
It really is wild. Well, welcome to today's deep dive. We are talking directly to you today, especially the residents and attendings tuning in, because we are getting into one of the most powerful but maybe most misunderstood procedures in facial reconstruction.
Right. Osseous genioplasty.
Exactly. Our mission today is a true masterclass in three-dimensional facial geometry. We're going to explore why physically cutting and moving the jawbone is so often vastly superior to what a lot of people think is the easy route, which is just sliding in a silicone implant.
It is one of the most critical debates in the field. That choice between a synthetic implant and an autogenous solution, meaning using the patient's own bone.
Because right now, roughly 5% of white North Americans have what we clinically call a receding chin. And with the cultural pressure for a strong jawline, fixing it is in huge demand.
Huge demand. But the clinical reality is that treating a small chin isn't just about making it bigger, it is a highly complex 3D puzzle.
Which brings us to the big question. I mean, it is totally natural to wonder why a surgeon would choose to pull out a reciprocating saw and cut into someone's skeleton when they could just, slide a piece of silicone in and call it a day.
The allure of the chin implant is obvious, right? It is technically easy, the immediate risks are lower, you can often do it under local anesthesia in the clinic.
Right, you make a pocket, slide it in, and you're done.
Exactly. But the limitations of that quick fix are just incredibly severe. Implants really only work for a very specific, narrow patient profile.
So who is the ideal implant candidate then?
They are okay for mild to moderate sagittal volume deficiencies, meaning the chin bone just needs to come forward a little bit at the pagonian, but crucially, the patient must already have a shallow labiomental fold.
Okay, so for everyone listening, if you trace your finger down from your lower lip, right before you hit the main part of the chin, there is that little horizontal dip. That is your labiomental fold.
Right, and an implant only works if that crease is already pretty flat. Because if you just shove an implant over the bone, you are going to deepen any existing crease and make it look incredibly harsh.
Ah, I see. What about facial proportions?
Well, implants cannot fix a face that is vertically too long. If someone has a really long lower third, an implant is useless. And they also cannot reliably correct asymmetries.
Because you were just putting a symmetrical implant over a crooked foundation. Right.
Exactly that. It
Wow.
usually just creates a larger, even more noticeable crooked chin. But honestly, the biggest reason we often steer clear of implants in complex cases is the revision trap.
The revision trap. Yeah, the clinical data on this was pretty eye-opening. Because the implant isn't just sitting neatly under the skin.
Not at all. To put a smooth synthetic implant in, you have to physically deglove the soft tissue right off the bone to create that pocket. And, I mean, the body hates foreign objects, so it forms a dense, rigid scar capsule completely enveloping the silicone.
Okay, so let's say it's 5 years down the road, the patient comes back, they heat the implant, and they want it out.
Right. When you take that smooth implant out, you are left with a non-collapsing dead space. That rigid scar capsule doesn't just magically shrink back down and glue itself to the bone.
It stays propped open like a little cave in there.
A cave that immediately fills with blood. You get a hematoma, and that pooled blood eventually organizes into even more thick scar tissue. So the way the soft tissue sits on the face becomes wildly unpredictable.
You take it out hoping they go back to normal, but instead they get...
Lumps, dimpling, sagging. It is a mess.
What if you try to be proactive and actually cut that scar capsule out? Just get rid of it so the tissue lies flat.
That is incredibly risky. You are right in the territory of the mentalis muscle, which controls the movement of the lower lip. If you go in there hacking away at scar tissue and damage that muscle, the patient can develop lower lip ptosis.
Oh, wow.
Yeah, lower lip ptosis is a nightmare. The lip literally droops off the face, exposing the lower teeth. It is terrible, functionally and aesthetically.
A visual popped into my head when we were prepping for this. It feels a lot like tailoring a suit. Using a chin implant is basically like stuffing shoulder pads into a jacket. It It works if you just need a tiny bit of bulk on a good frame.
Yeah.
But if the skeleton of the jacket is wrong, the shoulder pads just look tacked on and fake.
That is a brilliant analogy because with shoulder pads, the fabric pulls in unnatural places. In the face, that fabric is the soft tissue. Osseous genioplasty is like taking the jacket apart and actually re-sewing the structural seam.
Because you aren't scraping the tissue off the bone.
That is the absolute secret to the whole procedure. With a genioplasty, the soft tissue stays firmly attached to the bone segment you are cutting. When you move the bone forward, the soft tissue moves with it at a predictable 1-to-1 ratio.
No empty caves, no scar capsules.
Right. The fabric matches the new frame perfectly.
So if implants are a ticking time bomb for revisions, that completely explains why we go to the drastic step of cutting bone. But, I mean, you aren't just eyeballing a bone cut on the table. How do you mathematically map this out beforehand?
It is all in the blueprint of the preoperative evaluation. And the very first thing you look at is the position of the lower lip.
Not the nose or the forehead. I would have assumed you measure the chin against the nose.
A lot of people think that, but no. The lower lip dictates exactly how far forward the chin can go. There is a golden rule in facial proportion. You never advance the chin beyond a straight vertical line dropped down from the lower lip.
The lower lip rule. But let me push back on that for a second. Say a guy comes into your clinic, he has a big nose, a weak chin, and he wants that super prominent superhero jawline. If the bone can go anywhere, why not slide it past the lip to balance his nose?
Because if you violate that vertical drop line, the result always looks bizarre. The aesthetics of the lower face are rigid. If you push the chin out past the lip, it creates this severe concavity. They look like a cartoon character.
Ah, got it.
And if they have a recessive lower lip, which is common with the small jaw, you just have to accept that the chin can only go so far. Undercorrection is always better than overcorrection.
Especially because trying to fix an overcorrected chin is just a mathematical headache, right?
It is highly unpredictable. We know moving the bone forward brings the soft tissue at a nice 1-to-1 ratio, but if you have to reverse an overprominent chin and move the bone backward, the soft tissue does not follow it back at the same rate.
It just bunches up.
It lags. The ratio going backward is maybe 0.5 to 1 at best. So you move the bone back 4 millimeters, but the chin pad only retracts 2 millimeters. It is a clinical situation you want to avoid entirely.
Okay, so the lower lip draws this invisible wall we cannot cross. Let's go back to that crease, the labiomental fold. How does moving the bone affect the depth of that fold?
The biomechanics here are so fascinating. It is a true 3D puzzle. Whenever you advance the bone segment straight forward, you naturally deepen the labiomental fold.
So just pushing the bone out makes the crease sharper.
Right, and the exact same thing happens if you shorten the chin vertically. Like if you remove a slice of bone and make the face shorter, that also deepens the fold.
Okay.
But conversely, if you lengthen the chin vertically, stretching the bone down, you efface or soften the fold, you are essentially stretching the crease out.
That is a huge variable. If a patient already has a really deep ditch under their lip and you just push their chin straight forward, that fold is going to look like a harsh ravine.
Which is a classic mistake. You always have to evaluate if they also need vertical lengthening to stretch that fold out. And speaking of mistakes, there is a massive trap here for newer surgeons. It is called the orthodontic trap.
Yes, I found this part fascinating. If someone had braces as a teenager and their teeth are perfectly straight, why does the surgeon still need to worry about the bone being small?
Because straight teeth can be a brilliant disguise. A lot of patients asking for chin enlargement actually have a class 2 skeletal deformity. Their actual lower jawbone is structurally underdeveloped.
But they went to the orthodontist for years.
And the orthodontist tipped and tilted the teeth so the bite locks together perfectly. But the jaw underneath is still tiny.
Wow. So the soft tissue is still draped over a tiny frame.
Exactly. If you just look at their perfect bite and assume the skeleton is fine, you will miss the fact that the labiomental fold is distorted and the vertical height is totally off. You have to look past the straight teeth to see the structural reality.
Okay, so the surgeon has the blueprint. They respect the lower lip line. They know how to manipulate the fold. What does this look like in the OR? How do you make this precision cut without, ruining the face?
We do it under general anesthesia, and the approach is entirely intraoral, so no visible scars on the face. You make the incision on the inside of the lower lip.
But the exact placement of that cut is critical, right? You don't just slice into the deepest part of the gum pocket.
Never. You place the incision about 1 centimeter away from the deepest part of the buccal sulcus out onto the fleshy part of the lip. You make a superficial cut through the mentalis muscle, and then angle down to the bone.
Why the zigzag? Why not just cut straight down and peel everything off for a clear view?
Because you absolutely must leave a thick, robust pad of that mentalis muscle firmly attached to the bone. If you completely strip the bone, you risk unpredictable reattachment. The muscle just loses its grip.
And that causes the dreaded witch's chin we see in the literature.
Exactly. Severe soft tissue ptosis. The chin pad essentially slumps off the bone, looking like a witch's chin. So you only expose just enough bone to make your cuts and place your plates. Everything else stays glued down.
Okay, tissue is protected. Now for the intense part. You bring in the reciprocating saw for the horizontal cut. What is the safety margin here?
The absolute rule is you must make the cut at least 4 millimeters below the mental foramina.
The mental foramina, those are the two holes where the nerves exit the jaw, right?
Correct. The exit points for the mental nerves. They provide all the sensation to the lower lip and chin.
It totally reminds me of finding hidden wiring behind drywall. If you're taking a power saw to a wall, you need to know where the live power lines are. That 4 millimeter zone is avoiding the main electrical lines of the face.
Perfect analogy. If your saw strays into that 4 millimeter safety zone and catches the nerve bundle, you cause permanent numbness. They might never feel their lower lip again. You have to respect that boundary.
So you make the cut straight across. How far back along the jawline do you take the saw?
You carry the cut as far back as possible, right down below the roots of the molar teeth.
But if you just want to move the chin forward, why not just cut the very front point off and slide it? Why go all the way back?
Because if you stop the cut short, you create an hourglass deformity.
Like the jawline just pinches inward?
Yeah, it creates this harsh, unnatural notch right where the cut stops. By extending it all the way back to the molars, you displace a massive volume of bone. The thick tissue in the back of the jaw masks any small step off, so you get a totally smooth, natural jawline up front.
Okay, bone is cut free. You move it to the mapped out spot. How do you lock it down?
You secure the segment with titanium plates and screws. They hold it completely rigid while it heals.
What if the blueprint called for vertical lengthening? Like we talked about earlier, you have a deep crease and need to stretch the chin down. How do you lengthen a bone you just sawed in half?
You physically drop the bottom piece of bone downward. That creates an open gap between the two bone edges. To maintain that new vertical height, we interpose blocks of porous hydroxyapatite into the gap before screwing the plates in.
So you wedge in little structural blocks to act as a scaffold.
Exactly. It fills the void, stabilizes the bone, and over time, the patient's own bone grows right into that porous material.
Incredible. We've mapped the nerves, made the cut, wedged the blocks. Let's talk about how these opposing variables actually play out in real life. Forward projection, vertical height, fold depth. The coil cases really bring this home.
Patient examples are the best way to understand this puzzle. Let's look at two completely different presentations.
Let's start with patient one.
Right, so patient one is a 35-year-old woman. She comes in complaining of a small, weak jaw. On exam, she does have a small mandible, but her face is also vertically very long, increased lower face height.
And what's going on with her soft tissue?
Because of the skeletal mismatch, she has severe lip strain just trying to close her mouth. Her chin pad is constantly pulling upward, which completely flattens out her labiomental fold. No crease at all.
I'm guessing if you just threw an implant in her, she'd look like she had this aggressively long face jutting forward, and the lip strain would be worse because you were stretching skin over more bulk.
It would be a complete aesthetic disaster. So for her, the plan is counterintuitive. We need to advance the chin forward, but simultaneously shorten the bone vertically to fix the long face.
Wait, how do you shorten a bone?
You make 2 parallel horizontal saw cuts and actually remove the intervening slice of bone from the middle.
Oh, wow. So taking a slice out of the middle of the cake, tossing it, and squishing the top and bottom together.
That is exactly it. In her case, they advanced the bottom segment forward 8 millimeters and compressed it vertically by 5 millimeters.
And the result?
By pushing the chin forward, that totally flat crease deepened beautifully, giving her normal definition. And by removing the bone slice to shorten her face, the lip tension was completely eliminated. The forward movement stopped right at the lower lip line.
It is amazing how altering the hard scaffolding fixes the soft fabric tension. Let's contrast her with patient 2.
Patient 2 is a 28-year-old guy, also complaining of a small chin. But his exam shows a deep overbite.
Completely opposite structure.
Entirely different. He lacks forward projection, but his face is vertically too short. He looks compressed. And because of that compression, his labiomental fold is deeply creased. It looks like a harsh ditch.
And based on the mechanics, if you just advance his chin straight forward, that ditch gets even deeper.
It would look incredibly harsh. So his surgical math requires a 6 mm forward advancement coupled with a 6 mm vertical elongation.
This is where you drop the bone and wedge in those hydroxyapatite blocks.
Precisely. The vertical lengthening stretches his soft tissue downward, just enough to perfectly counteract the forward advancement. The result is a massive softening of that harsh ditch, plus the strong forward projection he wanted. Again, stopping exactly at the lower lip.
It really is this three-dimensional give and take. Fixing a deficit in one plane automatically pulls tissue in another.
That is the defining characteristic of genioplasty. You manage interconnected vectors, and it's exactly why implants fail the 3D test. An implant is a simple 1D volume fix for a complex 3D geometric problem.
Before we wrap, let's talk risks. Taking a saw to the mandible sounds intense. In actual clinical practice, what are the complication rates?
Surprisingly, medical complications are remarkably low. Temporary numbness in the lower lip is around 5.5% as the nerve recovers. Soft tissue infections are only about 3%.
Which is crazy low for an intraoral surgery where bacteria is everywhere.
Yeah, the real clinical reality is that the biggest complication is human error in the aesthetic planning.
The surgeon getting the math wrong.
That is the issue. Over-advancement is the most frequent error. Ignoring the lower lip rule and creating that bizarre look where the chin leads the face. Or failing to extend the saw cut far enough back, leaving the patient with an hourglass deformity.
So the bone heals, nerves are fine, no infection, but it's a failure because the geometry was miscalculated.
Right. When in doubt about advancement, the clinical rule is to err on the side of conservatism.
It just highlights how much respect this procedure demands for the face's structural limits. It is not about adding volume like spackling a wall. You have to respect the lower lip, anticipate the fold mechanics, and execute a flawless cut to protect those nerves.
It really is the ultimate tool for achieving true balance in the lower face.
It is a masterful procedure. But, digging into all this precise math leaves me with a lingering thought. We started this deep dive by talking about how the popularity of this surgery is tied to Western culture, valuing a prominent jaw as a sign of confidence.
We project deep psychological traits onto bone structure.
We absolutely do. We make permanent mathematical changes to the skull based on what society currently values. If skeletal beauty standards are just cultural constructs, how much of our psychology is dictated by a few millimeters of kin bone? And it makes you wonder, how will these permanent structural surgeries age over the next few decades if those cultural ideals ever shift?
It is a profound consideration for any resident or attending in this field. You are permanently altering the scaffolding based on the aesthetic language of today.
Definitely something to keep in mind the next time you look in the mirror or look at a patient's x-ray.